Thank you so much for the introduction, and it's a great pleasure to be with all of you here. This is the Jasmine Diabetes Institute, where I invite you all to come and visit us. So let's speak about the post-op bariatric care. I come from Kuwait, and we do 6,000 sleeve gastrectomy per year. So that's a huge number for an area of a population of 1.2 million among Kuwaitis. This is the agenda for today. And if we look at how diabetes is treated, we see that, lifestyle modifications, pharmacotherapy, and surgery, but we know things are a bit probably not going as in a pyramid, and it's a combination of an MDT teams. When we look at, what is obesity, we often use the BMI as a surrogate measure. However, we're trying now to move from the BMI and really trying to use the Edmonton or the ACE obesity staging system. So we no longer take people as a BMI as number and then decide on, is this the treatment and the best treatment that we would give to people? So we will really need to treat people according to their stages of disease. So if people are in stage 0, then they have nothing from the medical and mechanical and mental, then you do not need to treat the disease. If you're in stage 1, where you have the preclinical features, so if this is diabetes, you would look at impaired fasting glucose, impaired glucose tolerance. This is a stage 1. Stage 2 is when you have the comorbidities that you have developed, complications, and stage 3 when you have the end organ damage, and stage 4 is your end stage. So in diabetes, that's equivalent to your blindness and your renal failure. So this is the first thing that we really want to look at when we want to address obesity in our people. When I showed you, how we treat diabetes and what are the modalities, we look at it differently, and we look at 5 treatment options in our centers, and then we look at how many sessions we need to give these people and how we look at after the population. So even when you go to diet, now we have the remission clinic in Dasman, where we offer all people the total dietary replacement and the Direct Plus trial, and currently conducting a huge trial in Kuwait for the Direct Plus. Then we have the group who does the lifestyle, and again looking at their muscle strength, where we have a randomized control trial looking at people when we do home exercise, and we're only looking at 15 minutes home exercise of strength training versus our usual, what we recommend to people, of 150 minutes per week. We have the medications, and then we have the combinations, and lastly is also the surgery. So people do not need to go in the path. You address where people move into the path according to their staging of their disease. So, we know that bariatric surgery has contributed to our understanding of the pathophysiology. It has contributed to my career as well, and it is the most effective tool that we have today in weight loss. But we have to watch for, what we need to look after these patients when they undergo the surgery. So who can have the surgeries? We said people who have a BMI more than 40, see still the BMI is part of the guidelines, which will be probably changing, or people with BMI of 35 with obesity-related comorbidities. And now in the newer guidelines, you see people with diabetes with a BMI of 30 has been endorsed by most of the societies. But you have to have a 6-month minimum of documented diet failure, and the people must understand and accept the risks and to really agree to comply with the post-op program. So there are 4 main, bariatric surgeries that are currently available. So we have the lap band, and this is mostly practiced in Australia, where Dixon Group has the largest, group, and they have the best outcomes. Then we have the sleeve gastrectomy, which is the most popular procedure coming now among the world, but also very common in the Gulf. We have the Rowan-Y gastric bypass surgery, and very little on the switch. which needs a really comprehensive program and leaves people with a lot of complications. So if we just concentrate on sleeve gastrectomy for the sake of time, so it's a very effective surgery. You're going to have 25 to 30% of weight loss. It will improve your type 2 diabetes, and it will improve other obesity, complications. However, it is irreversible, and you have a risk of reflux, and it requires daily multivitamins, supplementations, and you have a risk of 15 to 20% of weight regain. Actually, in Kuwait, our weight regain is much higher than this, and you see it after 2 years, where at least 30 to 40% of weight regain post-surgery. And this is very common among the Gulf, countries. So it's an avenue to look at why are people having a higher weight regain, and probably what are we doing differently, and what are the interventions that we need to think about as well. So when we look at the Swedish outcome, obese SOS study, now we have the 20 years data, and you can see that in all of the data it shows the weight regain happens usually after 3 years, but it is almost sustainable, and this is not what we see. And you see, in the 20 years where people behave completely different to the usual care. And today we have more than 12 RCTs really showing, that the bariatric surgery is more effective than medical lifestyles in terms of glycemic control, diabetes remission, improvement of your cardiovascular risk factors, and even with your cancer rates, with, some acceptable complications. However, do remember, most of these, are happening because they are done in the centers of excellence, where they have, a comprehensive programs and following the guidelines. Where in our practice, most of the surgery is happening in a private practice and is probably unregulated. So if we look at obesity surgical team, these are the people that you would need in the team. You need the surgeons, you need the physicians, the endocrinologists, you need the specialists, dietitians. Even your anesthetists need to be, people who are trained in bariatric surgery. They will look into your dental care. If you have a poor dental care, you'll be better off to treat your dental care prior to doing the obesity surgery, because you're going to have loss of bone and a higher risk of, dental loss. So a lot of things you have to think of prior to, going into the surgery right from the beginning. And then you need the psychiatrist, the psychologist, and what is really important is the patient support group. That's something we miss in this part of the world. And if we look at, the diabetes clinic versus the metabolic surgeries in the Gulf, you see many of the diabetes centers, they'll have the diabetes educators, they'll have the dietitians, the podiatry, and the retinal screeners. Some will have the psychologist, and they'll have the defined pathways. But if we look at bariatric surgery, how many of the centers really have all of the above and really specialized in obesity bariatric surgery? So many of these centers might have the dietitians, but they're normal dietitians that are not practicing bariatric surgery, or a psychologist or a psychiatrist, just for the sake of checking the list and putting a tick on your checkbox. These are highly specialized people who need to have a special training to get into your obesity surgery team. So we look at, bariatric surgery very much like neuroendocrine tumors, where you have the full MDT team, and then you'll have the same thing. Is the disease in relapse or in remission, or is it, completely collapsed when we look at other things? The complications of bariatric surgery, we have a short-term versus long-term. So it's not without complications. Many of these patients will develop gallstones and will need to further go cholecystectomy. They will have the nutritional deficiencies. Many of them will require a contouring surgery. So they'll have the body contouring surgery, and they will end up in loose skins and psychological problems with weight regain of at least 30 to 40%. So what does the guidelines tell us? These are the guidelines, and it's the ACE, the TOS, the ASMBS have published the first guideline back in 2011, updated in 2013, and I will walk you into the latest update, that is the 2019, and what they have changed in the guidelines as well. So we have the routine screening for the deficiencies, and these are the minimum that what you would require. CBC, electrolyte, glucose, and liver function test. This is the full table, and I see many people, probably will be doing vitamin A and zinc and many other things, and then they will be not knowing what to do with the results when they get, the results. You have to do them in a specialized lab. So, many people measure the vitamin A comes back, abnormal, and then they're stuck with the results. Because you have to really understand what is the assay, did we use the actual right assay or not, before embarking on the treatment of these patients. So these are the updated guidelines that happened this year in 2019. And what we have new in the guideline is the vitamin D. You need a baseline and an annual vitamin D, and you have to replace with vitamin D3, and this is a grade B evidence. What is important that you have to know that immediately post-surgery, you're going to have high levels of vitamin D, so do not be happy about this. This is just immediate effect of the surgery because you're having the vitamin D, as you know, it's a fat soluble, but then you really need to replace these people for life. Anemia, this is updated in 2019. There is no need to do most important follow on your ferritin level, and then within the first 3 months, and then after it, you just need to do it 6 months to a yearly, and then annually after that. You have to do it for all your patients annually, and many of these patients will require, IV supplementations or oral supplementation on a long term. So initially, you need to make sure that all your patients are supplemented and make sure your bariatric pill includes the iron within their multivitamin tablets. Zinc deficiency, again updated in 2019, and this is, part of the routine multivitamin mineral preparation to make sure that all the patients are supplemented with zinc. And what we require that, if you use more than 15 milligrams of zinc, you really need to give them copper as well. So it's something that, again, I see many people giving 30 milligrams of zinc with no copper use at all. The B1, again, this has been updated in 2019 that we do not need to routinely screen for it. So only screen for it in the high-risk population and, patients who are presenting with heart failure and protracted vomiting, or if they have alcohol neuropathy. And, all what you need is 12 milligram thiamine. You can go up to 50 milligram of thiamine. What about diabetes? We know from Stampede and many others that the diabetes remission is happening in both sleeve gastrectomy and in gastric bypass surgery. So the new guideline for the first time updated the section on diabetes, and it tells you, do not be fooled about, if the diabetes is in remission or, you have stopped. You would still need to monitor these people and annually screen them for all the complications. So even if you have people who have done the surgery, they stopped the medication, you need an annual screening for all of these patients and at least keep screening for the microvascular. So this is new that has been updated, in the guidelines. So there has many updates, so please go through the updates and make sure that your pathways incorporate the new update of the guidelines. Vitamin B12, you'll be better off using the sublingual preparation. It's cheap, it's available in all of the Gulf countries, and very easy to take as well. Do not, use Neurobion as, an alternative to B12, because as probably you know, Neurobion has a B1, B6, B12, and if you use it, then you have a higher risk of neurotoxicity, nerve toxicity for your peripheral nerve neuropathy patients. And many of our patients, when we look at them post-bariatric surgery, they will have the neuropathy of various, different pathophysiological part of it. The calcium, please do not stop the discontinuation of calcium in supplements because the labs are normal. we're trying to prevent problems, and you'll be better off using, the calcium citrate because of its improved absorption, and then does not, require any gastric acid for the absorption. Nowadays, we're lucky because we have many of the bariatric pills that we have just one pill that contains most of the supplementation, with the exception of calcium, because you need to take the calcium divided during the day. So never ask a patient to take the whole calcium together. So that's because of the absorptions. And these pills are available, one pill, easily tolerable, and that's what I give for most of our patients as well. So when we look at, outcomes, so many of the things might get resolved so that your diabetes will improve, your sleep apnea will improve, but most of these patients will require their statins to be still on, so please do not remove your lipids because you have a slight improvements, but you need it for the cardiovascular outcomes. And they will be at a higher risk of gallstones, so we would advise all of these patients to give in, the urate acids right from the beginning for the first 3 months to prevent the gallstones later. We know that depression is very common, and even in our part of the world, there is more than 30% is associated with diabetes, and the same rate is associated with obesity. And post-bariatric surgery, that alcohol and drug abuse are increased after the bariatric surgery. And this has been, in a systematic reviews where we have 32 studies, and the risk for suicide increases after bariatric surgery. So there's at least 17 suicide cases for every 1,000 patients. So this is a risk that we have to address, and that's why you need to screen before the surgery if there is any risk of suicide, and address it prior to going into the surgery. And again, many of us probably do not routinely screen. Easy, effective tools, translated, validated in Arabic, that's your PHQ, it doesn't take even 3 minutes. We administer it to all of our patients in our diabetes and obesity clinics. So there has been increase of suicide, increase of alcohol use, and in our part we're seeing increased divorce rates. So this has been published, and we're looking at qualitative studies, the reasons behind increased divorce rate among people who are undergone the bariatric surgery. Again, there is insufficient physical activity, and when we look at these people post-bariatric surgery, they still have, the incomplete physical activity, where 60% of them are not even meeting the minimum guidelines. Sarcopenia post-bariatric surgery, it's an important issue, and easy. Just do the dynameter grip strength. Now we are establishing the normative data for the population of the Kuwait, is where you can really need to give you a predictions of who's going to have the sarcopenia. You need to have a higher protein intake in this population, and you have to really push your improved regular physical activity. So there has been many randomized controlled trials now, and there has been systematic reviews looking at the metabolic surgeries on bones, and this is the pathophysiological features of why we have the loss of the bone mineral density mass after the surgery. Again, there are many nutritional deficiencies that we have to keep an eye on and to look for. And you have the hair loss, the altered taste, your diarrhea, your anemia, and we have to keep supplementation of the people. When you look at post-op, you have to think, okay, what is the patient's concordance, and what about the marketing and the information? So many of the medications that they used to use prior to surgery probably will be ineffective due to the absorption, so they will have less absorption. So we have to look at the crushed, is it a rapid release? So if it's a rapid release or sustained release, we would rather not use them, and we change the preparation. Why is it important? Like some diseases, a case that has been referred to us who has myasthenia gravis, if you put these people into surgery, you will never be able to get them into control because of the absorption and the nature of the medication that they need for the rest of their life, for the treatment of their primary, disease. So please be open to can the surgery alter their life because of their absorption of the medications, and what I need to change from the medications. Many people given painkillers that you shouldn't use, many of your usual painkillers do not work on these people because of the nature of the pharmacodynamic changes and the pharmacokinetic changes post-surgery. When it comes to diabetes, we know it's extremely effective because what we need for diabetes is about 10 to 15 kilogram weight loss, and that's what has been also shown in the direct study. But what was really, initially when, I was practicing that, you can see the improvement within 1 to 2 days post-bariatric surgery, even prior to any weight loss at all. So, you'll see that they will not need anymore their insulins, or there were high dose of insulins, and even prior to any weight loss, they will be completely off their medications. And that's when you need to update your protocol. What are the pre-op levels that you're going to accept these patients on? Are you going to operate if people have a poorly controlled A1C? Will the pre-op levels influence your outcomes? What about the post-op? And what about the protocols for long-term? And many of the protocols have been developed and looking into these patients pre-op, the diabetes, post-op, and during the care as well. We know that people who undergo the surgery will have less death, and they will also have a better outcome from cancers. But please remember that is your fasting insulin level that is associated with the cardiovascular mortality, not the BMI. So the BMI was not the strongest predictor. That was your fasting insulin level. That is your strongest predictor for cardiovascular events. We published back in 2016 as how people do during Ramadan, and we saw that the nutritional analysis go really down from the protein intake. So these people are not at risk of dehydration if you allow them to fast, but you need a minimum of 1 year, but they have a very lower even protein during Ramadan. And then we went later to see that these people start to estimate the food completely wrong and start to have something very unique, similar to your anorexia, where they start to overestimate their calorie intake. So we looked into different methods how to best capture these people. We will have a separate talk totally on hypoglycemia and the effect of the post-bariatric surgery on hypoglycemia and the complications you would get. So, just to put this back into perspective, up to 1% of people who develop, who undergo the bariatric surgery will have difficult to treat hypoglycemia, and we have seen many more cases in your sleeve gastrectomy. Your diabetes will remit, your sleep apnea will improve in 1/3 of them, your lipid will be unchanged, so please keep them on your lipids. You'll have increased gallstones, you're going to have increased of micronutrient deficiency, so you'll need to keep them on supplementation for the rest of their life. You'll have increase in gallstones, and many require additional surgery, where we published on this, the body contouring and the qualitative life. So it is not fire and forget procedure. You need to have a lifelong procedure. So it's the balance you need to get right. It's an effective surgery, but we require the balance to get our people in the best position we require them. And with this, I would like to thank you all and try to keep it short.